Shortly after his appointment as the new Health Secretary, Andrew Lansley agreed to answer doctors' questions in a podcast. Today he'll repeat the exercise, giving Doctors Net UK members a unique opportunity to put their concerns and their questions direct to the policymakers.
Hello.
Do you want to just have a seat?
Thanks.
Thank you very much for your time.
Thank you. Pleasure.
Let's just crack on because there's lots of questions from the doctors. The spending review awarded £10 billion increase in health spending over this Parliament, but that's still less than the NHS has had in the past, and it doesn't match the 3% that was estimated to be needed. Are you happy with the budget that you've been given?
Well, I think in all the circumstances, I mean, I won't go on about the financial inheritance that the coalition government had, but it's pretty dreadful. And when you look really across the board, people are often having to accept some pretty substantial cuts. And the NHS is not in that position. We've got an increase, a real terms increase each year. So I think, in those circumstances, I think people in the NHS will recognise that is a remarkable commitment to the NHS. I think the point about the 3% increase, that broadly speaking is the level of increase in demand each year. So if I realise, and I think people right across the service realise, that if we are going to maintain and improve the quality of services that we provide, we are going to have to deliver efficiency savings each year. And they're going to have to be at least 3%, maybe more. That's what the programme across the service that's called QUIP, stands for Quality, Innovation, Prevention and Productivity. If we focus on those things, if we deliver those savings, all of that money will be available. And actually, in the service, we can be in a position where we feel, that I hope, people feel positive, not only that we are using money more effectively, but that by generating those savings, we do actually have the money to invest to meet additional demand and requirements.
And the Chancellor talked about the need for greater productivity. Do you share his views that NHS staff need to work harder than they do already?
Do you know, it's really not about hard work as such, it's about smarter work, frankly. And there are people the length and breadth of the country who I have met who have worked out how they can deliver better productivity. I mean, if you're on a ward, for example, at Great Western Hospital in Swindon, where they're telling me, look, we've taken responsibility through the Productive Ward programme. The time we spend with staff with patients has gone from, I think it was something like in the sort of 38% roughly to over 50% in the space of weeks. Now, of course, when you actually think about how to do that, how to be more productive, it does then, of course, sometimes lead to changes, and sometimes people find that hard. But we can't be in a position where the rest of the economy is expected to be more productive all the time. We had a decade leading up to this year where the NHS was losing productivity overall. We have to increase productivity each year. That's the essence of it. But you talk to anybody in any line of work and they will tell you increasing productivity is sometimes just about doing things smarter and better, not just about how hard you work.
You've been consulting on the white paper and the consultation period closed a couple of weeks ago. Can you give us any information yet on the lessons that have been learned?
Well, a lot has come back by way of the response to the consultation, and we will, of course, before we publish the bill and proceed with all the implementation, we will take full account of all the things that have been said to us. And, I mean, I think I can tell you now there will be some changes. Not big changes, but there will be some changes.
Any headlines?
Yes, you're tempting me, but I think I should tell everybody in a more ordered fashion, not least laying a document before Parliament when we come to settle that out. But what I think is quite important to say is that I was very struck by the support there was in principle for what we're setting out to do. Great deal of support for patients' empowerment. Subsequent consultation, I think, widely welcomed about giving patients much better information and exercising more control. I think I would say a lot of what's come back is it's not just about choice, because choice is sometimes the thing that patients aren't particularly fussed about. They care to have choice where it's available, but actually even more important than that is that they really feel that when decisions are being made about their care, they have information, they are consulted, the decisions are made with them. That principle of no decision about me without me, that shared decision making is the essence of what we're aiming for. The idea we should focus on outcomes, very widely supported. I think important sense came back in the consultation that people felt that while we focus on outcomes, we must also be aware that there is a place for performance management. I think my point would be you don't need government to be trying to give you a set of targets about how you manage your own performance. Our job is to focus on outcomes. The service's job is to be aware that they should be accountable for the results that are achieved. Within the service, however, there is a lot of work to be done in trying to make sure that the way in which performance is managed, including setting targets for performance, works with clinicians rather than against clinicians. That business of breaking down what has sometimes seemed the divide between management and clinical responsibility, bringing those two things together. Third thing I say is about devolution of decision making. I mean, quite clearly, a lot of people in the, particularly in general practice, were enthusiastic about taking more responsibility, somewhat apprehensive about what it looks like, which is precisely why, in response to the consultation, one of the things we will need to do as soon as we can go through the immense amount of detail is set out precisely what the shape of the distribution of PCT functions are. Some will be abolished, some will transfer to local authorities, some will transfer to the NHS Commissioning Board. Obviously the clinical commissioning activity in bulk will be the responsibility of the commissioning consortia. But I think actually when we go through that, many of the concerns that came back about how commissioning consortia can take on these responsibility will be made, I think, more manageable, understandable, doable when people can see the exact shape of what they need to do.
Are you still working on the detail here then? Because a lot of the noise that is out there amongst the doctors is we need as much detail as soon as possible.
I mean, when I was at the National Association of Primary Care, for example, I thought they did a very good job in producing their essential guide to GP-led commissioning, which I thought was a pretty helpful document. From our point of view, of course, many of the principles of what we're hoping to do were in the subsequent consultation document after the white paper on commissioning. It's quite important. I think we gave people the opportunity to respond to that. We will now make sure that the essential points of what I was just talking about what precisely are the commissioning functions that transfer from PCTs to the consortia are properly answered. I think we will need to give people an indication of how they can be supported in doing that, including in terms of the overall envelope for management costs and so on. We need, through the greater work on what the commissioning framework looks like in terms of outcomes, and we need to consult on what outcomes the commissioners themselves are being asked to produce, which will link to what the commissioning board as a whole have as the overall outcomes for the NHS.
So it's still quite a few stages.
So there's a few of those things to do, but actually I would just say this: there are a lot of instances where, and I can see different places across the country, sometimes GPs collectively through consortia, they're answering many of these questions for themselves, because I'm not proposing to specify what the geography should be of consortia. I'm not proposing to specify what the internal constitutional governance should be. So a lot of those things can be, and some of those relationships locally, can all be established now, and they don't depend upon the government telling people.
But it can be messy and quite costly, can't it, if people, replicated around the country are all feeling their way through a system. Would it not be better to
Well, I don't think it's
have
necessarily duplicatory. For example, if you're thinking about what should the size of a consortium be and what should the geography be, and how do we as a consortium want to organise ourselves as a partnership or a community interest company or a limited company by guarantee, I mean, those are things I think people need to decide for themselves. And the idea that it's happening in a lot of places across the country is only natural, frankly, rather than something that's of itself really very duplicatory.
A number of doctors put in questions asking you for the evidence base for your proposals. One specialist trainee asks, in such times of financial austerity, why are you ring-fencing several £billion for yet more structural reform of the NHS?
Yeah, well, I can see where that question is coming from, called public good, private bad. And, it's not quite like that, actually. And we were very clear in the white paper and the subsequent document. There is good evidence derived from some of the last stages of fund holding that actually when they were starting to come together as locality commissioning groups and take a total purchasing responsibility, they were beginning to shape to a much greater extent the levels of hospital admissions, and they were starting to shape community services. They were starting to take more of a grip on prescribing rates and so on. We can see in if you look at America, There's a lot in America we don't want to reproduce, but then when you look in America at where the quality of healthcare and the control of cost of healthcare is being done more effectively, it's generally by physician-led groups. And GP-led commissioning in this country is not something I've invented. It has been around, and practice-based commissioning groups have been doing this thing. And it's actually the places where they are most enthusiastic about now taking and using these new responsibilities and freedoms are precisely the places where, as practice-based commissioning groups, they were given probably the greater opportunity in the past. So in places like Cumbria and Northamptonshire, where I've been with both sets of GPs, they're keen to go. And they can demonstrate, in the context of the responsibilities they've had already, that GPs have turned around in some cases, like in Cumbria, the commissioning activity, and in Northamptonshire, they're really shaping it. And I would invite whoever's put that question forward, just go and talk to some GPs who've been doing this and say to them, is there any evidence? And they'll say, yes, evidence, the best kind of evidence. We can show you it.